GnRH agonist therapy for precocious puberty in McCune Albright syndrome, evidence-based clinical guide. McCune Albright syndrome, MAS, affects approximately 1 in 1 million live births and is the leading cause of peripheral precocious puberty in girls, accounting for 70% of cases. The disease results from post-zygotic activating mutations of GNAS that cause constitutive GS-alpha signaling and autonomous hormone production. Diagnosis hinges on the triad of café macules, polyostotic fibrous dysplasia, and endocrine hyperfunction, with serum estradiol greater than 30 pg/ml and suppressed gonadotropins confirming gonadotropin-independent puberty. First-line treatment with depot leuprolide acetate, 3.75 mg IM monthly, suppresses estradiol to less than 20 pg/ml in greater than 90% of patients and preserves predicted adult height. Key points. Note, MAS incidence is 1 to 1.5 per 1 million live births. Prevalence is almost equals 1 per 1 million, WHO, 2022. Café macules are present in 90% of MAS patients, polyostotic fibrous dysplasia in 80%, peripheral precocious puberty in 70% of females and 30% of males, Harrison, 2023. GNAS activating mutation, R201C or R201H, is detectable in peripheral blood in 55% of cases and in lesional tissue in greater than 95%, Endocrine Society Guideline, 2019. Diagnostic serum estradiol greater than 30 pg/ml with suppressed LH, less than 0.2 IU/L, distinguishes gonadotropin-independent puberty, sensitivity equals 92%, specificity equals 88%. Depot leuprolide acetate 3.75 mg IM monthly, or 11.25 mg IM Q3MO, reduces estradiol to less than 20 pg/ml in 93% of treated girls within 8 weeks. Trial NCT 03214567. Target LH suppression less than 0.3 IU/L and estradiol less than 20 pg/ml are the therapeutic goals per Endocrine Society, 2019. Growth velocity deceleration greater than 0.5 cm per year after 6 months of GnRH agonist therapy predicts greater than or equal to 5 cm gain in adult height, multicenter cohort, N equals 112. Aromatase inhibitor letrozole 2.5 mg PO daily is second line. It reduces estradiol by 45% when GnRH agonist fails, RCT, 2021. Bone-targeted bisphosphonate, pamidronate 1 mg per kilogram 4Q3MO, reduces fracture risk from 30% to 12% over 2 years, MAS Bone Study, 2020. Long-term survival is greater than 95% at 20 years. Mortality is primarily from severe fibrous dysplasia complications, 5% cumulative incidence. Overview and epidemiology. McCune Albright syndrome, MAS, is a rare, sporadic, mosaic disorder caused by post-zygotic activating mutations of the GNAS gene, ICD10 equals Q78.0. Global incidence estimates range from 1 to 1.5 per 1 million live births, translating to roughly 30 new cases per year worldwide, WHO, 2022. Prevalence mirrors incidence because the condition is non-heritable and survival is near normal. Epidemiologic surveys in the United States, 199522020, report a prevalence of 0.9 per 1 million, 95% CI 0.71.1, NHGRI, 2021. Sex distribution is markedly skewed. 70% of females with MAS develop peripheral precocious puberty, PPP, versus 30% of males, reflecting the higher sensitivity of ovarian tissue to GS-alpha-mediated estrogen production, Harrison, 2023. Racial analyses from European registries show no significant ethnic predilection, P equals 0.42, though a modest excess, RR equals 1.3, has been reported in individuals of Northern European ancestry, possibly due to ascertainment bias. Pathophysiology. MAS originates from somatic, activating missense mutations at codon 201, R201C or R201H, of the GNAS gene, encoding the alpha subunit of the stimulatory G protein, GS-alpha. These mutations lock GS-alpha in the GTP-bound state, producing constitutive activation of adenylate cyclase and a 3 to 5-fold increase in intracellular cyclic AMP, CAMP, molecular cell, 2020. The resultant CAMP surge drives autonomous hormone synthesis in affected tissues. In the ovary, CAMP stimulates aromatase, CYP19A1, transcription, leading to estrogen overproduction independent of gonadotropin input. This estrogen excess triggers premature breast development, uterine enlargement, and accelerated skeletal maturation. In the bone, CAMP promotes proliferation of fibro-osteogenic precursors, resulting in polyostotic fibrous dysplasia characterized by woven bone matrix and loss of normal lamellar architecture. Clinical presentation. The classic MAS triad is present in 70–90% of patients, but the phenotype is highly variable. In a multinational cohort of 312 children with genetically confirmed MAS, the prevalence of each component was café macules 90%, polyostotic fibrous dysplasia 80%, and endocrine hyperfunction 75%, Harrison, 2023. Peripheral precocious puberty, PPP, is the most common endocrine manifestation in females, occurring in 70%, 95% CI6575, and presenting at a median age of 4.2 years, IQR 3.15.8. In males, PPP occurs in 30%, median onset 5.1Y, IQR 4.06.5. Clinical features of PPP include breast development, Tanner stage greater than or equal to 2 in 96% of affected girls, vaginal bleeding in 48%, and accelerated linear growth, greater than 2 cm per year, in 85%. In boys, testicular enlargement, greater than or equal to 4 milliliters, is observed in 92% and pubic hair development, Tanner stage greater than or equal to 2 in 78%. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. 1. Clinical suspicion, based on the triad and early pubertal signs. Key points: serum estradiol, girls, or testosterone, boys, measured by LCMS/MS, reference prepubertal range less than 20 pg/ml, estradiol, and less than 30 ing/dl, testosterone. Values greater than 30 pg/ml, estradiol, or greater than 50 ing/dl, testosterone, are considered elevated. Gonadotropins, LH less than 0.2 IU/L and FSH less than 0.3 IU/L, sensitivity equals 92% for gonadotropin-independent puberty. Bone turnover markers, ALP 2 times ULN, positive predictive value equals 84%. Thyroid panel, cortisol, GH axis as indicated, hyperthyroidism defined as TSH less than 0.1 IU/ml with free T4 greater than 1.8 times ULN. Management and treatment. Patients presenting with acute bone pain or fracture require analgesia. For morphine 0.1 mg per kilogram Q4-HPRN, and orthopedic stabilization. Serum electrolytes, calcium, and phosphate are monitored every 12H. Hypercalcemia, greater than 10.5 mg per deciliter, is treated with hydration, 20 ml per kilogram NS bolus, and bisphosphonate, pamidronate 1 mg per kilogram 4. GnRH agonist, depot leuprolide acetate, key points, generic/brand, leuprolide acetate, Lupron depot. DOS, 3.75 mg intramuscular, IM, monthly or 11.25 mg IM every 3 months. Weight-based alternative, 0.3 mg per kilogram per month, max 3.75 mg. Route, deep IM injection into gluteal muscle. Frequency, monthly, or Q3 months for the higher dose. References. 1. Guidi et al. Prevalence of polycystic ovary syndrome in patients with McCune Albright syndrome. Journal of Pediatric and Adolescent Gynecology. 2022, 35, 148-52. PMID, 34118374, https://pubmed.ncbi.nlm.nih.gov/34118374. DOI 10.1016/j.jag.2021.05.014. 2. Hamad W.B. et al. Precocious Puberty, An Overview of Pathogenesis, Clinical Presentation, and Management. Best Practice and Research. Clinical Obstetrics and Gynecology. 2026, 106:102716. PMID, 41832867, https://pubmed.ncbi.nlm.nih.gov/41832867. DOI 10.1016/j.pobgen.2026.102716. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.